Sir, we are live now. With all your permission, I am starting this
Right,
session.
please.
A very good afternoon, everyone present here. I welcome all the participant doctors as well as participant on this session. Let's welcome today's speaker with great honor, none other than Professor Dr. Sunil Kumar Agalwara, sir. Sir has done MBBS, MD, Professor at the Department of Pediatric, Sardar Vallabhbhai Patel Postgraduate Institute of Pediatrics. Today, sir is going to speak on a topic Down syndrome. Let me tell you overview of the topic. Down syndrome, also known as trisomy 21, is a genetic disorder arising from an extra copy of chromosome 21. This leads to distinct physical features, intellectual disabilities, and development delays. Individuals with Down syndrome may experience various health issues, including heart defects and increased susceptibility to certain medical conditions. To know more about this topic, I would like to one of the specialists on this, Dr. Sunil Kumar Agarwala, sir. Sir, over to you, sir. Kindly proceed from here.
Thank you. Thank you very much for your kind introduction. And I can say now it is 12 plus. So good afternoon, dear doctors. First of all, I thank the IJCP team total for taking pain and everything for organizing this wonderful platform to discuss on a particular common topic, Down syndrome. I'll tell you, this is, as rightly said by Faraz, that this is a genetic disease. If you ask me, Down syndrome, what does it mean? Why it is known as that? Why we are worried about that? If we are knowing in which way it is going to help in our day-to-day life. Syndrome means it is a symptom complex. That means in one individual, you get a lot of features. For an example, I'll tell about some eye problems, some nasal problems, some chest problems, some intestine problems, some heart disease. Everything will be there in one. Then we call in medical science as syndrome, that you all know. And why it is down? Many times people ask us, sir, is it the mental retardation or mentation or IQ is down? That's why it is known as down. So there are so many queries. So we will be going one after another, and I'll be saying in which way we are interested to go ahead. So let me tell you, Down syndrome is named after Langdon Down. He is a scientist. As he found the condition in 1887, way back to 150 years back, this syndrome was coined by the expert known as Down. That's why it is known as Down syndrome. And Down syndrome can also be called trisomy 21 or Down syndrome. And many times we call this as Mongolism. And you see, this is a girl of 24 years. She looks like a Down syndrome, and she is a Down syndrome, but she is able to manage her life in day-to-day life like a normal individual. So why we are worried for this? I'll tell you. Because of the symptom complex, we are telling it is Down syndrome. It is a genetic disease. Many a time blame goes to the mother and father. No one is responsible. It is by default during the process of zygote formation, because we know the sperm contains spermatid, and this spermatid and the ovum, they got unite and they are unicellular. That means they are haploid in number, but once they conjugate, there will be diploid number. In one cell, you get 23 pair of chromosomes. Now, in one chromosome, by non-disjunction, if it is triple chromosome, because of non-separation, non-disjunction, that became trisomy. The meaning of trisomy is that in one autosome, you find there are three number of chromosomes. Instead of a pair, there are three, and that's why it is known as trisomy. And you know, autosomal diseases are related to 22 pair of autosomes. Sex chromosomes are X and Y. If XX, it is female. If it is XY, it is male. Now, during the process of mitosis and meiosis, or first, when the sperm and the ovum, they unite together, at that point of time, if anything goes wrong during the process of zygotogenesis, what happens? That is the time for genetic disorder. If I ask you which is the commonest genetic disorder known to us, it is Down syndrome. That's common. Then number two, why we are worried? Because even if they have a normal life, but they have may not have, majority have mental retardation. We must know this is a genetic disease. There is no cure to this, but we can try our level best by occupational therapy, by speech therapy, by sensory integration, by behavioral therapy, and by, you can say, we say play and everything, so that they will have an amicable life just like a normal individual, and we can have, they can go to the school. So everybody will have some degree of mental retardation. So that's why this is the condition which cannot be corrected throughout life, but the mental retardation is the common. So I can say, suppose you ask which is the genetic disease commonest causing mental retardation, irrespective of male or female, that is Down syndrome. Which is the preventable cause? That is thyroid hypothyroidism, because hypothyroidism can be prevented if it is diagnosed in the early life by TSS screening. There are many countries across the world, they do diagnose hypothyroidism by newborn screening program, and they pick up that and they give thyroxine supplementation throughout life, that can be prevented. But hypothyroidism mental retardation is prevented, but Down syndrome mental retardation is not prevented. But due to some continuous therapy, we can have some, you say, amicable life, or a life which is possible to pass every day, and occupation, everything in his or her life in a Down syndrome child. So coming to one question, who is affected by Down syndrome? How much? What is the incidence and prevalence? One child in every 800 to 1000 birth has Down syndrome. This is almost one world, or you can say in India as well. 2.5 lakh people in US have Down syndrome on an average. Approximately 21,000 to 27,000 babies with Down syndrome are born every year in India. So you must know that which is the hub. India has the highest number of people suffering from Down syndrome in the world. Why highest number? Because the population is high. India is a continent comprising of 30 states and are having many union territories. The total population now surpassed the population of China. Now it is 1.48, I mean 1.28. That means 142 crore population is the India's population. So every disease you say, the highest burden is inside the India. So also the population. So the Down syndrome, if you say every year on an average 21,000 they are born. So if you accumulate every year, they are going to survive. So what decide the survival of the Down syndrome? It is, the answer is associated with heart disease or not. If suppose someone is having heart disease, then definitely they succumb at first or second year of life due to complication of the heart disease, due to development of the pulmonary hypertension, due to non-operation of that congenital heart disease. And in India, there are many surgeons as of now, they do not show interest in doing surgery of Down babies. Why? Because they say if they can have normal heart, but still then they cannot do anything for the mental retardation. So there are many mindset in the cardiothoracic surgeon as well in as of now in Down syndrome. Now coming to what causes Down syndrome. Normally each egg and small sperm cell contain 23 chromosomes, already I told. The union of these creates 23 pairs of 46 number of chromosomes. Occasionally an egg or sperm cell does not develop properly and contribute 24 chromosomes instead of 23, and that is one additional. And that additional chromosome, if it is number 21, then it is known as trisomy 21, which is otherwise known as Down syndrome. If that happens to number 13, that is known as Patau syndrome. If that happens to number 18, that is Edward syndrome. So these three trisomies are common. There are other trisomies, but they are not common. So that's why we do not discuss. So always remember, this is the only trisomy which is having hypotonia. The other two trisomies, Edward and Patau, they are having hypertonia. And the association of congenital heart disease in them is around 80 to 100%. But here it is to the tune of 50 to 80%, like that. So the association of congenital heart disease is lesser than in comparison with Edward and Patau. And Edward and Patau, they are not going to survive beyond 6 months of life usually. So any trisomy is going to survive beyond 6 months of life is none other than Down syndrome. There are many faces, they look like down faces, but not necessarily they are having down. Some feature like horizontal palmar crease can be seen in normal population also. So by getting one feature of the down in one normal child or individual, we cannot term them as they are suffering from down. To say down, that is the holistic approach. From top to bottom, you see they are usually short stature, they are usually chubby, they may have a heart disease, they may have small microcephaly, they have motor delay history, and they are having IQ low. There are some eye features are there, some features in the mouth cavity, they are having horizontal single palmar crease, they are having sandal gap, first and second toe, the gap is there, they are having a Kennedy reach, and usually you see internipple distance is widened, they may have hernia, they can have all intestinal blockade like you can say duodenal atresia, jejunal atresia, even congenital megacolon. Some down may have your arch defect in the form of cleft lip and palate as well. So this is popularly known as trisomy 21. Now I'll tell you, this is otherwise known as Mongol child. Mongol child because it looks like a Mongol child. But the Mongolian spot, which is a normal entity in the lumbosacral zone, which is bluish discoloration, which vanishes automatically by age of 1 year, that is not to be confused with Mongolism or not to be confused with Down syndrome. Now, Down syndrome results if the extra chromosome lies with the number 21. The features of Down syndrome result from having an extra chromosome in each of the body cell. If you take any cell, and how to confirm that it is Down syndrome or not. You can send the blood or karyotyping. Karyotyping can be done from the buccal mucosa as well. And you can send usually blood sample. You can go the pair of chromosome in cell. It is the 21st chromosome. Instead of having 2, they are having 3. And if it is XX, that is a female Down syndrome. If it is XY, that is a male Down. So Down syndrome also referred to as trisomy 21 because the presence of 3 number of chromosome that lies with the 21st number of autosome. So this we can say that if we are saying, but I mean that what are the things they are associated with Down syndrome. So if we are one by one, we are saying the things which are affected with the Down, how do they look like? That means they look like may have eyes that are upward slanting eyes, low set ear, small mouth, making the tongue appear large. Usually they have a protrusion of tongue. If you see a baby having protrusion of tongue, it could be a cerebral palsy child, it could be a Down syndrome, it could be hypothyroid, it can be a, you can say mucopolysaccharidosis by tongue protrusion. Even the tongue protrusion can occur in some other like Pili-Robin sequence because there is narrow mouth cavity so that the tongue appears large. Some babies may have short necks, small hands, and short fingers. Adults are often short stature by length or by height. How will children with Down syndrome develop compared to other children? Is there any difference? Children with Down syndrome can do most things that any child, young child can do. They can walk, they can talk, they can dress, they can toilet train, but usually develop later than other children. That means they are having all skill of all domain of development like gross motor, fine motor, then you say speech, then personal social behavior, everything, it happens at a later age. That means there is neurodevelopmental delay in Down syndrome. These Down syndrome usually results in varied degree of mental retardation. You see nowadays some Down syndrome, they goes to the school, they may drop out because of non-compliance with the pace of increase in the school. They may not acquire that type of IQ, so that's why they drop out from that. But still, there are few Down syndrome, they can go to matriculation or can go to first level because of mild mental retardation. But this varied presentation or mental retardation varies from subnormal intelligence to imbecile, idiot, or you can say profound mental retardation. Some people with Down syndrome hold supported employment and frequently live in semi-independently life. There are many Down syndrome because of hypotonia, they walk at a broad-based gait. Sometimes because of that too much of hypotonia, they are having motor delay. That means they may start walk after 4 to 5 years. So something like that. And because of this hypotonia, ligament laxity, they may line up with protuberant abdomen. You can see umbilical hernia in them. And I will tell the most common endocrinal disorder associated with Down is hypothyroid, which is treatable. So that means any Down syndrome comes to us, it is an important entity that you should evaluate underlying hypothyroidism is there or not. So T3, T4 TSH is a mandate. If you get a high TSH more than 10 or 20, then definitely you have to treat. Sometimes this helps to increase the IQ of that child in a case of Down syndrome. So coming to other associations, coming to top to bottom, I have told upward slanting eyes, low set ear, then protrusion of the tongue. Then in eyes, you can get coloboma of iris, you can get cataract. Sometimes you can say brush-filled spots in the iris, very typical of Down syndrome. Then coming to down below, intestinal malformation requiring surgery in the form of atresia. Visual and hearing impairment occur in 50% more. Thyroid problems, already I told, and that is very probably Down syndrome is a pre-leukemic condition. In the long run, that may lead to development of either ALL or AML. Epilepsy, diabetes, and Alzheimer's disease do occur more frequently in Down children. So there is special health problems in related to Down syndrome, higher rate of infections. Usually Down syndrome, they are prone for recurrent ARI. One of the most common cause of death in them is severe pneumonia. So immunization has a very tremendous role in cases of Down syndrome. So one child should get all immunizations as per NIP. If the parents can afford, they can take other vaccinations which are not their placement in the NIP. They can take as per the IAP protocol, like for an example, meningococcal vaccine. You can give typhoid conjugate vaccine. You can give flu vaccine annually. So these all mandate vaccines you can give in a Down child because they are hypoimmune and they have a compromised immune system and decrease in number of T cells. So as well as T and B, and that is the reason they often come to us with recurrent pneumonia and recurrent sepsis. Dry mouth caused by breathing associated with upper respiratory infection, periodontal disease, they have very early onset of childhood caries, and sometimes it is exaggerated by a lot of bad oral hygiene. They do not brush well. They have always secretion into the mouth cavity. Always there is pulling of saliva into the mouth cavity. Some children, they have high grade of GR leading to GRD. So all those factors, that means the propulsion of the the ciliated epithelium of the airway into the outside is defective, and there is, you can say, IgA defective, that secretory immunoglobulin IgA is defective, and as such the T cell mechanism is defective. All those things, they lead to repeated upper and lower respiratory infection in Down syndrome, and that is the reason the vaccination plays an important role in them. So now, what extra examination you have to do in Down syndrome? Already I told, beyond this typical examination of the Down child, already I told one endocrinal disease has to be excluded, that is hypothyroid, by doing thyroid function test. Then coming to examination of the heart. If you get a murmur, definitely you have to rule out all type of congenital heart disease, but the commonest being endocardial cushion defect. Usually they present with mild cyanosis and congestive heart failure. They can have BST, they can have AST, they can have tetralogy of Fallot, they can have even your Epstein anomaly. All type of congenital heart disease is possible in a case of Down, and the association is near to the level of 50 to 80%, and that's the common. So you have to evaluate the heart of a Down child. Any child comes to the first time, likely thyroid function test. The next investigation is cardiological examination. Then vision and hearing, because I told there are defective vision and defective hearing. So you have to go for Vera test or autoacoustic emission, and vision test, vision acuity, and if possible, that visual evoke a response has to be done. Regular medical care, including childhood immunization, is the need of the hour for cases of Down syndrome. As I have already told, there is a protrusion of the tongue, and you see this pulling of saliva into that. Higher incidence of periodontal disease, early onset of childhood caries is there. Chronic dry mouth, gerostomia, and fissuring of tongue and lips are the ailment in cases of Down. Aphthous ulcer recurrent, oral candidial infection, acute necrotizing ulcerative gingivitis, that is trench mouth. You can say this is cancrum oris, all types, even your gingivitis, even your cheilitis, all things are very common in cases of Down syndrome because of poor oral hygiene. Sometimes underdevelopment of hypoplasia of the midfacial region, smaller bridge of the nose, and bones of midface and maxilla. So they give rise to a smaller face. open bite or class 3 malocclusion in there, just like your cases of thalassemia and sickle cell anemia, you get malocclusion. So these type of things are also possible in Down syndrome. Tongue may protrude and appear to be too large. Sides of hard palate are abnormally thick, but gives appearance that the palate is narrow with a high vault. It looks like a bilirubin sequence. That is a palate, thick palate with high vault. Occasionally, palatal cleft are also found, even if they are uncommon. Reduced degree of muscle tone in the lips and cheeks, and that's the reason they have a difficulty in speech, dysarthria, and sometimes they may not speak in a good voice. But always remember, these Down children, they love music. If you have any doubt that you put on music or your mobile ringtone, they will dance. Dancing is an art, or it is the gift given by the God to the Down syndrome. They love music like anything. So if you go on thinking that what has happened to the face and mouth cavity, small nasal passages contribute to mouth breathing. So that's why they are having obligate this mouth breather. That means the mouth, this nasal orifice is narrowed down. So they are always having a open mouth and tongue protrusion. Less space in the oral cavity for tongue, affecting speech, mastication, and natural cleansing of teeth. Force of tongue greater than force of teeth, causing class 3, and this malocclusion, everything is possible. So microdensia occurs, hypoplasia, hypocalcification are common, congenitally missing teeth, partial anodontia occur in 50% people with Down syndrome, and delay in the eruption of dentition. This is also seen in this. Delayed dentition in malnourished child, in hypothyroid we know, but one of the condition is Down, where delayed dentition is a entity. Expressive language of children with Down syndrome is commonly more delayed than receptive language. They can understand, but they cannot express. Contributing factors to expressive language delay include mental deficiency, relatively large tongue, excessive salivation, poor oral closure, dry and thickened mucus, dental anomalies, hearing problems, and aphasia. All those things lead to, including hypotonia, lead to delay and difficulty in speech. Disordered articulation in children with Down syndrome reflects a delay in speech development. So all those things are very important, not only the hearing assessment, but the speech therapy is also a domain of management of Down syndrome. So I mean to say that there are multiple therapies out there. One of them is occupational therapy, speech therapy, behavioral therapy, sensory integration. All those things should be started early. That we say a Down syndrome, early intervention is a mandate. Now, in Pan India, there are almost all states, in all districts, they are having DIC. And this is known as District Early Intervention Center. Each DIC is provided with a speech therapist, provided with a speech pathologist, then you say hearing assessment, vision assessment, and occupational therapist, and the physiotherapist. All those people, they take care of Down syndrome as well. There are some centers, Pan India, that they do admission of the Down syndrome, they evaluate, and they wanted how the parents can go for multiple therapy for a betterment of their life. If they are having a mild mental retardation, they can go to school, they can pace with at par, may not be equal to normal kids of that age. So sometimes parents always ask, doctor, is there a cure? No, there is no cure. Just like somebody will ask, is there a cure to hypertension? Is there a cure to diabetes? We say they are manageable. So likewise, this is also a manageable disease. But I have already told, the survival and not survival depends on associated or presence or absence of heart disease. If someone is a heart disease detectable, and if it is a small VHT, it doesn't matter. If it is a moderate to large VHT or endocardial cushion defect or congenital cyanotic heart disease, usually they go to pillar to post for an operation. If they are free of cost, then they are landing to many Satyasai hospital across the country, but the cardiothoracic surgeon, they usually not happy to operate in cases of Down syndrome. So that's why they came back. And in due course of time, there is occurrence of pulmonary arterial hypertension. That is an indication that not to go for surgery, and they die because of refractory heart failure. That is the usual story with those who are having left to right shunt with sizable size and landed up with PH and landed up with refractory heart failure. So Down syndrome is not caused by anything either of the parents did or did not do. It is not the fault of the parent. So that's why they must know. But always remember, if there is a question, if the first child is Down, whether they go for the second child or not. Yes, it's a very good question. But always remember that if it is a trisomy, or if it is a translocation or it is a mosaicism. Usually this mosaicism and trisomy, they do not recur. So chance is by chance. But if there is a translocation, then definitely there is every chance that the second child will be down. But always remember, so always the karyotyping is important to know the nature of a mechanism of Down syndrome. It could be mosaicism, it could be a trisomy, it could be translocation. Then translocations are again of many types. So you have to know what causes this. If you know that, you can predict what will happen to the next pregnancy. So karyotyping is also mandatory. So if you get a Down syndrome, I have told you from top to bottom, you examination of the cardiovascular system, that is CVS, what type of heart disease is there, ruling out of hypothyroid T3, T4, TSH, and we know they are having hypoimmunity, T cell dysfunction. So that's why they have to be given all immunization, whatever possible. If they are poor or below poverty line, or if they cannot afford, they should get all vaccinations mandate at the NIP. Now NIP, National Immunization Program, they are giving 12 antigens. And in the long run, they are coming up with typhoid vaccine and as well as HPV vaccine. So all vaccines, whatever is there in poor setting, they should be offered. So this is the management sake we have to take care. Who has an increased risk of having a baby with Down syndrome? So parent who already had one child, if it is a translocation, then it is not. Parent who has a rearrangement involving chromosome 21, that's the same thing. Mothers over 35 years. If you go back to 21 years, 22 years, can it happen? Yes, it can happen, but the chance is less. But as the maternal age increases, the chances of Down syndrome increases. So suppose elderly primary, more than 30 years. So all gynecologists, they are going for antenatal diagnosis. Antenatal diagnosis can be possible in the first trimester by chorionic villus biopsy, or you can say that CVS is the one way, or genetic study can be done in the first trimester. But in the second trimester, you can go for amniocentesis and alpha fetoprotein estimation in the maternal blood. Usually in Down syndrome, it goes down. So that means you have to see whether you are dealing with that. Now there are triple tests, there are now quadruple tests to screen the lady whether the pregnancy outcome is having Down syndrome or not. Sometimes ultrasound of the fetus, that has knuckle thickness, so biparietal diameter. So many pointers are there which point towards the probability of having a Down. But always remember, increased maternal age is a high risk factor to have a Down child. Similarly, I can tell you, increased paternal age have a high chance of Marfan syndrome. So if you know paternal age increases, Marfan syndrome, maternal age increases, that causes probability of Down syndrome. So can Down syndrome be diagnosed prenatally? Yes, already I told. Alpha fetoprotein blood test, a screening test can be done around 16th week of pregnancy. Amniocentesis and chorionic villus biopsy, again in the second trimester, and chorionic villus biopsy is below before 12 weeks. It can be possible, so that we know whether the fetus to be born or not. So that is a debatable topic. Down Syndrome Federation of India, co-founded by Dr. Rekha Ramachandran, offers daycare services to individuals with special needs. There are many NGOs working across the country. They are going forward and giving. Some NGO fund is diverted towards the management of this, and they are giving quality life and periodical checkup. And we know that there is no true cure for Down syndrome, but they can be manageable, they can be trainable, so that their life will be in a better way. Those who are not having cardiac disease, they can go to even fourth decade, fifth decade. Now they are going up to sixth decade because of all immunization, better care, better oral hygiene, better training, better occupational therapy. All those things can allow them to have a workable or a feasible better life. If you go back 3-4 decades back, the Down syndrome is mental retardation. Nothing can be done. Now the time has changed. Even Down syndrome in a family, you can't prevent that they will not stay in the family. They have to stay, and only thing, they have to compete with other peer groups. And definitely you can manage them in such a way that with their mental IQ, whatever is there, they can lead a normal life. Sometimes they are having some job in the society, whatever is possible at their IQ level, that is possible. They can go to the school. I have seen in 30 years of my experience, 2 Down syndrome I have seen, they have gone up to 12. Class 12, and they are doing wonder. One of them now got +2, and she means a girl, she is now reading in +2 in English medium school. But otherwise, if you don't take care, and it's possible because these two children, their parents are teachers. That's the reason, after knowing that down, they are going for management from early intervention from early part of life, so that the outcome is better. Whatever it should have been there, it is much better than if you don't intervene the child at the early period of life. So if I say Down syndrome, it is not the end of the world there. You never know. Nowadays, the couples are marrying at a later age. The girls are marrying at 30 years. Once they are standing on their one leg, that means they are telling that the job is there. Everything is there, now they are going to marry. Now, increased maternal age as well as increased paternal age, both of them are more common to have down babies. And these down babies, if I say now, you can have multiple therapy centers, almost all states across the country. You can take their child to them. I mean, the doctors are the best person who can guide well. And definitely, I told they have to be screened at any point of time. If they come with persistence of fever, hepatosplenomegaly, lymphadenopathy, one has to bring the diagnosis of leukemia. Because Down syndrome, the chances of leukemia is near about many 40 times higher incidence of leukemia in Down syndrome is there. You have to remember. If the child comes all of a sudden with quadriparesis, you have to remember there is atlantoaxial dislocation will be there that will compress the cervical cord, and they can come to this. So there is a laxity of the atlantoaxial joint. It is because of acetabular ligament is lax, so they are very prone for quadriplegia at their some point of time. So the lifespan of them now has gone to fifth, sixth decade. Usually they don't go beyond that. And the determining factor is congenital heart disease. Which congenital heart disease comes next? I told this is the endocardial cushion defect. They are having all intestinal atresia, duplication of the gut, congenital megacolon, even cleft lip and palate, even you can say tracheoesophageal fistula, all are entities with them. Now, in my experience, I have seen many down, they have converted to leukemia and died. Many down, they come with pneumococcal pneumonia if they are not vaccinated. So I urge that this is the high-risk child who should get all the vaccine either by NIP or by NIP and IAP immunization schedule or by IAP schedule if they are able to afford. So coming to some quiz questions. Is Down syndrome caused by something the mother does during pregnancy? Answer is no, it is not due to some defect in the pregnancy. It is due to the first day where the spermatid and the ovum, they got united. At that point of time, if there is a failure of disjunction, that means separation of the 21st chromosome, that occurs the origin and genesis of Down syndrome. If the same thing happens with other chromosomes like trisomy 18, trisomy 13, some other defect will be there. Only trisomy which is having hypotonia is down. Only trisomy which is commonest, they are down. Only trisomy they are having, you say survival beyond 6 months of life, it is down. So Down syndrome is, we the clinician, and we tell you should diagnose by looking at the child. Even you can say and smell that it is Down syndrome on day 1 of life once the baby is delivered by a gynecologist. So can Down syndrome be prevented? Yes. If it is being diagnosed antenatally, it can be prevented. That means the baby is not allowed and you can go for NTB. If it is a full-blown, I mean full perfect diagnosis by chorionic villus biopsy, and you know, so if you want, the parents can want, they can go for abortion. What factors contribute to mouth breathing? Already I told, because of the large tongue, appearing large tongue, narrow cavity, mouth cavity, and there occurs always protrusion of the tongue and high bulk. They all are factors leading to poor oral hygiene, and that is the reason they have malocclusion of the teeth. They are having periodontal disease. They are having early onset of childhood caries, whatnot. Everything is possible, and that lead to dysarthria and disarticulation, leading to speech delay and speech defect. What are the some health problems associated with Down? Already I told cardiac one is most important. In CNS, you can get mental retardation and intestinal congenital malformation. Sometimes you can get hernia. Sometimes you can get, because of hypotonia, they have hyperlaxity of the joints. And last but not least, usually the most important concern by the parents is mental retardation, and which is not treatable. But I will tell each and every Down child should be subjected for thyroid screen so that which can be picked up. If at all it is there, we can increase the IQ of the Down child by giving thyroid replacement throughout life. So the answers are written here. Down syndrome cannot be prevented. Mouth bleeding is occurs due to narrow nasal passages. Already I told. Heart defect, intestinal malformation, vision and hearing assessment is demanded in Down syndrome. So now coming to some points of Down syndrome, there are, if you see the palm, this is known as dactylography. This dactylography, you can see here this horizontal simian crease is you can get bilateral, sometimes you get unilateral, sometimes you may not get. And there is shortening of the digits brachydactyly. That means short digits, short hand is usually the feature. Sometimes there occurs hypoplasia of the middle phalanx of the little, that is known as arachnodactyly. So now if you say there occurs ATD angle, and this ATD angle is usually not narrow, it is obtuse. It is obtuse, more than 90 degree in case, because the ATD angle is placed distally. And that's the reason the palmar, what you say, this palmar print, I mean the palmar print in Down syndrome, a lot of study loss, a lot of research has been done and ATD angle has been done. But for a clinician point of view, 5 points I will tell. Number one, this is a genetic disease which cannot be preventable. This is done by the non-disjunction mostly, or by mosaicism, or by translocation involving the chromosome number 21. And there are a lot of features are there, but always the common feature in all is hypotonia. If your child is not having hypotonia, even if it looks like that, it is unlikely. And if you get heart defect, hypotonia, down faces, then 99.99, it is a case of Down syndrome. If you diagnose, never neglect the cardiological evaluation heart, and never neglect the endocrinal disease associated, that is hypothyroidism. So if you diagnose, you have to go for all those entities, whether they are existing in that or not, then train the parent and tell them, this is not the end of the world. Some parents, they are not blessed with a kid. You are blessed with a kid which is trainable, early intervention, and send them to DIC centers at the district headquarters hospitals, which these children can be picked up and be trained. If not, there are there are a lot of institutes are there, and they are having all those facilities. So they can refer to them. And if they are willing to go for cardiac surgery, they can be. But if at all they are interested, they can spend money, they can. But usually I tell, where the money is not taken, the institutes like you can say, there are many institutes now, Satyasai Institute in Raipur and in Whitfield, Bangalore, they are not charging any money, and usually they are not interested to go for any cardiac surgery in cases like Down syndrome or in severely malformed children. So with this, I can tell you that this Down syndrome is definitely a topic to be discussed, and I thank all of you for your important time, and you have enrolled, and I tried my level best to discuss the common points, what a clinician, what a doctor must know, what you can do so that we can have a quality life of a Down child if he or she has been placed in the family. But we have to go with him, and nowadays this early intervention, the outcome. So thank you very much. Thank you very much. Now it is over to your IJCP team. If there are any questions, I'd love to answer.
Thank you so much, sir.
Yes.
Thank you for your wonderful insights upon the topic that you have shared with us today. We have received few questions from the participants. I would like to put across to you those questions.
Right, please.
Yeah, the first question is, which hematologic disorders are associated with Down syndrome?
Okay, this is a good question. I will tell you, there are two types of hematological disorder associated with Down syndrome. In early part of life, they can present with fever, hepatosplenomegaly, purpura, just mimicking like leukemia, that is known as transient myeloproliferative disorder of infancy in Down syndrome. And they do not require any therapy. Automatically, the child will come out of this transient myeloproliferative disorder in infancy. That is one hematological disorder. Second, I have already told that in the long run, by end of the first decade or thereafter, they are very prone to have leukemia in them. That means 50% chance of AML, 50% chance of ALL. So any child in the Down child comes with a prolonged fever, lymphadenopathy, or hepatosplenomegaly has to be screened for whether the child is having leukemia or not. So these are the two major entities, hematological disorders, coexist in a case of Down syndrome. Yes.
Thank you so much, sir, for answering this question. We'll move to the next question. And the question is, how does trisomy 21 mosaicism affect Down syndrome?
Okay, mosaicism means what? There are two cohort of population. One cohort will have 22 pair of chromosomes along with X and Y or X and X, that is 23 pair of chromosome. Another will have trisomy, so that means two population of cell. And when it happens after one series, means one sperm and one during meiosis, the first one is escaped during the second step. So there are many cohort of cells they will produce from that. They are having normal cell and another cohort will be having trisomy. So that type of is 3 to 4%, you can say. 95% is due to non-disjunction, 3 to 4% are due to mosaicism, and less than 1% is due to translocation. So what I mean to say, the mosaicism means it is just like in your floor, you are having some black dots and some are white. Just like that, there are two population of cells. One cell category, they have a normal number of chromosomes, 23 pair, and another, there is a excess of chromosome will be there, they are having trisomy 21. So I mean to say, if this is there, then trisomy. Yes.
Thank you so much, sir, for answering this question. We will take up the next question that we have received.
Yes.
And the question is, what is the risk for recurrence of Down syndrome in mothers and siblings of a patient with Down syndrome?
Okay, that means the same question. What is the probability of you are getting, if the first child is down, then what is the probability that the second child will be down? Or
Right.
in other words, the mother is blessed with a Down syndrome first, and what is the probability of the next pregnancy? Always this answer cannot be told if you do not get the karyotyping. So if you have karyotyping, you know what is the mechanism. The mechanism is, if it is commonest one non-disjunction, then the chance is 0. I can say the chance is 0. It is by chance. Then number 2, if it is mosaicism, then the chance is 0 by chance. But the less than 1, if it is translocation, then the chance is 100%. So what I say, if you know the mechanism of genetic disorder in that Down child, if it is a translocation, that means definitely we say that this is the recurrence is 100%, and there is every chance that second child will be a Down syndrome. That will deciding factor. Yes.
Thank you so much, sir, for answering this question. We will move to the next question. And the question is, what is included in the first semester of prenatal screening of Down syndrome?
Yes, first trimester is always difficult part, because mother is just now knowing and enjoying that she is pregnant. That is being possible once the baby has gone 4 weeks or 6 weeks, like that. So beyond completion of the 12 weeks, I mean first trimester, first 3 months of pregnancy, in that period, how you know whether it is down or not? There are two things, amniocentesis and another is alpha fetoprotein, which are possible to get in the second trimester. Now only option left out in the first trimester is chorionic villus biopsy, CVS, and exposing that blood to genetic study. That means chorionic villus biopsy in genetic study, that is the only way that we can know the chances of or happening of Down syndrome in them or not. Again, I will tell, sometimes ultrasound can tell because of knuckle thickness and because of biparietal diameter, they can say, but the authenticity, the reliable diagnosis in first trimester, answer is chorionic villus biopsy, and leading to genetic or genodiagnosis is the answer, whether the fetus is down or not. And beyond that, second trimester, there are two options. One, you go for amniocentesis, or this in maternal alpha fetoprotein level. That is, we are saying that triple test, now quadruple test, in all those things can be done to know what is the probability of down. But the highest probability is because of the genotyping and genomic diagnosis, that is from chorionic villus biopsy. Yes.
Thank you so
Oh,
much, sir, for answering
yes.
this question.
Yes.
We will take up the last question for today's session before concluding it. So the last question is, what are the possible behavioral and psychiatric complications of Down syndrome?
Okay. Behavioral and psychiatric complications are many. I'll tell you starting from one, that they do not speak well. Speech defect is the ultimatum or is the most important tragedy in Down syndrome. Number two, they are having poor IQ. So that's why they cannot express their feelings. They know, but they cannot express. That is another. That's why sometimes they dance with the music. But the opposite part, they are always low esteem. That means the mood is not always good. They are very much moody. Temper tantrums are there. Sometimes you can get they are hyperactive, hyperkinetic. And some children also have autism along with Down syndrome. So a lot of behavioral problems are there in the domain of speech, in the domain of personal-social domain. And definitely, I told one is low esteem, another is they are depressed. Sometimes they can go to hyperactive, and some of them can go to autistic like spectrum disorder. And the most important part is the speech problem in them. And because of low IQ, they cannot cope up themselves with the other peer group of that age. So definitely, it is not only a problem for the family, but also a problem for the happen child, Down syndrome child. And it is not that any country is devoid of Down syndrome, any part of the world where human race is there. There is every chance that 1 in 800 you may get, and more the age of the mother, I mean pregnant mother, there is every chance of Down syndrome. That's the reason that nowadays that the educated girls, those who are marrying at later age, because they want that they should earn and they should have their livelihood and they should stand on their foot. That means there are every chance goes that it not that everybody will have Down syndrome, the probability increases. So once you have 35 year plus first pregnancy, then the chances is equal to near about 1 in, I can say, less than 300. Sometimes it can be less than 250 as well. So that's the reason. Elderly primary beyond 30 years, every lady, or beyond 35 years, every woman should go for screening of the Down syndrome during their pregnancy. But otherwise, getting a Down child in 30 years or 20 years, or you can say lower than 20 years, then definitely this is because of spontaneous mutation. Yes, Batul.
Thank you so much, sir. Thank you for answering all the questions so efficiently and with such wonderful insights and all of your experience that you have shared today with us at our platform. Thank you so much for that. We are really grateful to have such an enlightenment speaker and an eminent speaker like you at our platform. It really gives us great pleasure and honor. So thank you so much for that, sir. So with this, we would like to conclude the session here for today until next time, so that we can come up with another interesting topic and can communicate with the viewers in such an interesting way with all the questions that we have received. So thank you to all the viewers as well for their ardent participation. So with all your last comments, sir, we can conclude the session here for today.
Yes. I must thank Batul, Faraj, all the team of IJCP. And finally, I thank all the doctors who have logged in. So I wish all the best. And definitely the last point, Down syndrome, they are not the defect of luck or by the God. Everybody has chance. In each pregnancy, they can have Down. If at all some family is blessed with a Down child, nowadays, because of early intervention and all kind of therapy, they can have a normal life just like other children. Thank God that they are not non-ambulatory. They don't have any physical disability. They can walk, they can speak, they can hear, they can see. Everything is possible. Only thing, you have to train them in such a direction they can lead a normal life. So with this, again, I thank all of you for logging in, and I hope again another topic on neonatal care today by the team of yours at the time of 4:30. So thanks a lot.